So as we all know, with improved access to ART globally, HIV has become a chronic illness, and as life expectancy has increased, a variety of disabilities have been described. A previous study done a few years ago at Baylor, Malawi, found a high rate of disabilities through caregiver report when comparing HIV-infected children with their uninfected siblings. And when the types of reported disabilities were broken down, hearing-related issues comprise 35% of the disabilities reported. There have been several other studies done in a variety of settings looking at the prevalence of hearing loss in children living with HIV, and has ranged from 20 to 38% in various settings. And this prevalence is higher than uninfected children, or in the case of the US, the prevalence of hearing loss in the general population in children. So our current study was a follow-up study based on the high report of hearing-related difficulties in our patient population. We wanted to determine the prevalence of hearing loss through formal audiologic testing in the children attending the HIV clinic at Baylor. We also wanted to look at if there were any clinical or sociodemographic factors that might be associated with hearing loss in these children, as well as the association of hearing loss and quality of life. This was a cross-sectional study done from December 2013 to March 2014. HIV-infected patients aged 4 to 14 years old that were attending clinic at Baylor in the capital, Lilongwe, were enrolled. Children younger than 4 were not included in the study due to the battery of testing. It was believed that they wouldn't be able to perform all of the tests. Caregivers and patients, when able, were completed sociodemographic questionnaires as well as a standardized pediatric quality of life survey, and a clinician reviewed the electronic medical record. Children completed an array of audiology tests at a nearby location, African Bible College. They underwent otoscopy, tympanometry, otoacoustic emissions, as well as audiometry. Hearing loss was defined as greater than 20 decibels hearing loss on audiometry. And those with hearing loss were then evaluated whether or not they required a hearing aid fitted. And this was determined by the audiologist depending on the severity of the hearing loss, the nature of the hearing loss, whether it was unilateral versus bilateral, the impact of hearing loss on the level of function, and usually this was in relation to school, and a variety of other factors, including did the patient and guardian want the hearing aid, did they really understand what the hearing aid meant, as well as certain physical exam findings. Factors thought to be associated with hearing loss were explored through regression analysis to generate age and sex-adjusted odds ratios, to compare clinical and sociodemographic factors between those children found to have hearing loss versus those children not without hearing loss. The prevalence in our study was 24% of children, of the 380 children tested, had hearing loss in either ear. And of those 90 children that had hearing loss, 23% of them were referred for hearing aid fitting. In regards to the type of hearing loss, the majority at 83% was conductive, which implies a problem with blockage of the ear canal or damage to the tympanic membrane or middle ear. 14% was sensorineural, so damage to the hair cells, the auditory nerve, or the brain. And then a very tiny percent, at 3%, was mixed. In regards to the age breakdown, you can see that most patients in both hearing loss and no hearing loss were in the 5 to 7 age range, and the next highest was 8 to 12, and then the rest were kind of in that 4-year-old or 13 to 14 range. And there was about a 50-50 male-female distribution in the study. We found that there was no difference in age, gender, or family income between those children with hearing loss and those without hearing loss. Caregiver perception of hearing loss was related to the child actually having hearing loss with an odds ratio of 5.9. However, only 40% of caregivers accurately perceived that their child had hearing loss. A variety of common screening questions for hearing loss were included in the questionnaire, including the need for the guardian to repeat something for the child to be able to understand, the child having difficulty following instructions, the child not speaking clearly, and a family history of hearing loss. The first three questions were found to be associated with hearing loss, while family history was not associated. However, you can see that each individual question did not capture a large percentage of those with hearing loss, at 41%, 30%, and 24%. When evaluating other health conditions that might be related to hearing loss, there was a strong association with a history of ear drainage or frequent ear infections, which again goes along with the high prevalence of conductive hearing loss that we found. And a history of malnutrition recorded in the electronic medical record was also associated. It appeared that children with hearing loss also tended to report experiencing other disabilities, such as physical disabilities, cognitive disabilities, or visual impairment. And hearing loss did not appear to be related to a history of meningitis or current nutritional status as measured by BMI at the time of the study. Most patients in both the hearing loss and not hearing loss group were on ART. In the hearing loss group, 98% were on ART and had been for an average of 4.6 years. There was no significant difference between the age of ART initiation, the duration of ART, or various measures of CD4 between those children with hearing loss and those without hearing loss. Viral load was not included in the study, as routine viral load testing had just been rolled out in Malawi prior to the study, and the lab was not capable of processing so many samples. Children with hearing loss were more likely to have presented at a more advanced stage of illness at enrollment at Baylor Clinic. They tended to be more likely to be WHO stage 3 or 4. We evaluated some questions about their performance in school and school attendance, and we found that among children older than 5 years, those with hearing loss tended to be less likely to attend school, but if they were attending school, their school performance did not appear to be affected by the hearing loss. We also evaluated their quality of life and found that between children with hearing loss and those without hearing loss, there did not seem to be an effect on the quality of life, overall quality of life. However, when broken down into the different categories of physical, emotional, social, and school functioning, children with hearing loss tended to report poor emotional and school functioning. And the school functioning questions were related to was the child having trouble keeping up with his schoolwork, having memory problems, having trouble paying attention. And so it seems that they're reporting having more difficulties, although we saw from the previous slide that their school performance didn't seem to be affected. In conclusion, 24% of HIV-infected children tested had hearing loss in either ear. And 5% of the total children tested actually qualified for a hearing aid. And importantly, caregiver assessment of hearing loss was not always reliable. There were some significant associated factors, which included WHO stage 3 or 4 in enrollment, perceived hearing loss by the caregiver, history of frequent ear infections or ear drainage, as well as positive screens for subtle signs of hearing impairment. There were some limitations to the study. Due to budget and diagnostic constraints in Malawi, the etiology of hearing loss was not able to be determined in every case. And certain risk factors, such as exposure to common ototoxic medications used in Malawi, such as gentamicin and quinine, were not reliably documented. And as in several of the previous studies mentioned of hearing loss in HIV-infected children, we were not able to have a control group of HIV-uninfected patients. And the prevalence of hearing loss in children in Malawi is not currently known. The way forward using the results of these studies, we really need to educate our patients and caregivers about the signs of hearing loss, their risk for hearing loss, as well as screening and treatment options. Ideally in our setting, universal screening for hearing loss would be done, but in resource-limited settings, targeted screening of high-risk patients should be done using some of those associated factors mentioned earlier to prioritize. And finally, none of the screening questions were perfect. And so we need to identify better screening tools to be used both at our setting as well as more rural ART clinic settings throughout Malawi and the world. I just wanted to give thanks, especially to our patients and their caregivers who participated in the study. And then here's the studies that I mentioned previously. Thank you.